welcome to the first episode of our little podcast called Just Our Two Cents. Reason for the name is it's our opinion, man. It's just basically corridor talk, just bouncing off ideas of each other, and we just thought, why not share with everyone, Some of the things we say might just come in handy and useful not only to our athletes but our colleagues, physios, and just if it reaches anyone and benefits their lives, I think we've done our job for the day.
Yeah, or not. I mean, if you don't want to listen to our BS, that's cool too. Everybody's entitled to their opinion, and that's what we're about. Just stating our opinion, and just talking about things that matter to us and things that we find interesting. So, I think the big thing I want to talk about firstly, welcome Wade, and how was your week today? This week?
It was cool. Yeah, man. Busy week, which is always good in our field. So,
particularly during this time now.
Especially during this time, and I think we're all finding it a little difficult trying to find our feet again as therapists. Not only as therapists, but everyone. Trying to find normality again, or the new normal, like everyone's starting to say. Yeah, man. It's just happy to see that things are slowly getting back to what we've known. Athletes coming back, being able to train again and things like that. And it's kind of, I think I speak for us both, it's kind of our passion working with these like elite level athletes and things like that. So getting them back on the fields or on the courts, on the track, gets us to do what we do best, or at least what we think we do best.
For sure.
And then how was your week, man?
Yeah, my week was interesting as well. And, specifically relating to what you're talking about now, getting everybody back and just seeing kind of also the mood that the different like levels of clients are in. Like, for instance, your elite athletes, where their motivation lies, and whether they're sort of still anxious about dealing with the whole COVID situation and what happened during the lockdown period, how they were able to train, were they not able to train, and how that's affected them mentally, how we position ourselves in terms of motivating them and getting them sort of inspired for training again, which was interesting. Also, I had a very, very interesting case with somebody that I've been seeing for quite a while now, a client of course, that I've been seeing for quite a while, that presented with something quite difficult and complicated, and was quite humbling actually for me, because I've been in the game for such a while now, and you think that you get to a point where your ego starts to take over, and you think, I've seen everything, I've done everything, nothing can surprise me. And it was good actually to get my ego in check and actually sit down with the client and say, look, I don't know what's going on here, but let's try and figure something out. Let's work together to find a solution. Exactly. And let's kind of brainstorm through this together. And it was interesting to see her reaction to that, and also how my ego kind of took a kick in the nuts, and it was good for me actually. It was very good.
Exactly. I think it's we talk about it all the time. It's we labeled it as the power of I don't know, and I think it's kind of the best form to kind of stay on your toes and actually check your facts or check your diagnosis, run the idea or your diagnosis by a colleague, and kind of say, if this was the case study, would you kind of end up on the same result, or would you tackle it from a different direction? Do you see something that I missed out? And I think a great mentor to me was the late great Michael Mabasa. He told me basically the day you think you know everything is the day you should retire, because then you become a liability to your athlete, to your patient. So I think it's also us as therapists so important that we should understand that we won't know everything. We can strive to get to that level, but with the change of technology and new studies being brought out, we always see that maybe this works a little bit better than what I've been using, or should I use a combination, or is it patient specific? And obviously it's patient specific, but just understanding that, you know, our normal bias approach on, if I see a knee and it's on the lateral knee, ITB, glute area, you know, if we keep going into that bias kind of approach, we might miss like the little details and then not only impact like kind of our ego and our process thinking that way kind of is to a detriment to the athlete or the patient.
Yeah, for sure, and particularly that what you picked up on now was the bias, in which I always thought I had pretty much under control, because I'm fairly aware of, you know, how my brain forms patterns and how it's comfortable it is to fall into those habits with those patterns. But yeah, it's still evident it's an everyday fight, you know, and if you're not kind of thinking that, almost having to check yourself consistently, it's very easy just to fall into those habits, you know. But I was wondering what your experience with this was, because it was interesting for me to see the client react in the way that they did, because I thought I said it in a way that was fairly confident, you know, like, I don't know what's going on here, but I'm willing to work with you. But I still expected sort of an adverse reaction from the client, and as if to say, well, you know, if you don't know what's going on, what am I doing here? Why am I wasting my time, you know? But
yeah, and I think you know, those memes where, you know, what we see ourselves as physios and what people and what your mother and what your friends think, I think it's kind of, I think we should have, or in the case of the two of us, I think we have moved away from, you know, patient comes into physio, they have neck pain, I fix your neck pain, go home, and that's it, you know. I think we've taken the approach, or at least I have taken the approach of more like, I'm giving the ownership. It's your body. You need to take ownership of this. I'm basically, you the captain of the ship. I'm just the lighthouse, kind of showing you the way, you know, trying to guide you through this process. And yeah, man, like, you know, if the patient understands that, listen here, this is kind of, if it's that complicated and it is like a, you know, trial and error, you know, let's eliminate these and then work through this. If this works, this does, you know, this shouldn't work. You get what I'm saying? And yeah, like, you know, if the athlete or the patient has been through that process, you know, and they've been at that kind of level, they're willing to kind of, you know, trial and error, understand it's, you know, and especially if the patient trusts you, you know, if they've worked with you before, you know, I think they would probably be more accepting in that case, which is a experience that I have personally found as well, you know. So if I just laid on someone I don't know on my first session, that's a bit troubling, you know. But if I've worked with this athlete for a year, 2 years, and we've always had good results, then I think that, you know, they would probably take it a bit more like, listen, you've gotten me through these years, and we've always sorted it out. So, like, you know, I trust you to let's figure this out together. Let's see what works. Let's get me back there. So yeah, man, I also think it's obviously the rapport between yourself and your patient or your athlete, and the time spent with them, and, like, you know, getting good results in the past, you know, and then them really trusting you. So that would be my approach, you know. Honestly, I would, on the first session as a therapist, if I wasn't sure on exactly what was wrong, I would, in my approach, would be, listen here, this is option A, it could be this, it could be that, but let's start rehabbing it. I think it might more likely be option A, so let's give you the treatment for option A, and give you the rehab towards that. So now we're playing the elimination game. So if you do improve following this protocol, then it's option A, you know. But if we're not getting the results that we like, let's move now more towards option B, or at least that's how I would play it. And we're being honest here, because this is our opinion. We want to kind of create a transparency. So I don't want athletes and patients to see this and like, oh my word, he does not know what he's doing. It's just, we try to be transparent. And I think rather than being definite and saying it's option A, and you come back the next week and say, like, I've done all your things, it's not getting better, and now going, ooh, you know, it could be this. That's creating doubt, I think, with the athlete or with the patient. But if you very transparent and say, listen, I'm not 100% sure what's going on here, you know, but 70% of me says that, you know, it's looking like this. The other 30% is saying this, but, you know, let's go with this. Let's first rehab to where I prioritize, you know, option A, and then, like I said, if that's not working out, then we change our technique, we change our approach. I don't know if you like that style.
I mean, and let's be honest also, I mean, you know, physio isn't magic. There's no sort of like
silver bullet.
Yeah, there is no silver bullet. It's all really a case of, unless there's some serious pathology going on, I mean, the body's going to sort of follow its natural course of things. And I feel personally that our job is to kind of just manage that healing process for the client and kind of just guide them. We're not really changing anything there.
Exactly.
I mean, the body's going to heal in a certain way. It might not heal, it might heal in a maladaptive way, but it's still going to get to an end point, man. And our job really is to kind of manage that end point so that when the client gets out to that end goal, they're in a better state than they were before. You know? So it's not really us performing magic during that phase. So ultimately also I feel like, you know, you can't necessarily do anything really harmful unless you are being sort of malicious doing it or negligent.
Yeah.
But as long as you focus on the key principles such as getting somebody stronger, getting them more stable, getting them better at doing what it is that they want to do, then throughout the rehab process you can't really necessarily go wrong, even if you don't necessarily have a precise diagnosis, you know.
Exactly.
So, but what was interesting for me was like I started thinking about why is it that we're not necessarily comfortable with saying that to clients anymore, you know, or at all. Like,
yeah. So I like I said, I just think they come to us, they want the answer, they come to us for help, you know, and that's what they expect. They expect us to have all the answers sometimes, and sometimes we don't, unfortunately, and not unfortunately, but that's the truth, you know. But it does not mean that we can't find out, you know. It does not mean we can ask a colleague, do some reading, you know, finding out, kind of prepping for the next session. So I would say, you know, we can treat symptomatic, and I mean, not saying it's easy to treat the symptoms, but it's very easy, or at least my approach is never like, let's not treat symptomatically because, you know, this is tight for a reason, or this is causing us discomfort for a reason, but why is it tight? Why is this causing discomfort? You know, what is the root cause? So it's easy to, or I keep using the word easy, but you're able to treat the symptoms, you know, but in my goals is never just to get them feeling okay for a week or two, you know. My goal is to like, let's sort this out and let's prevent this from happening again. And that in turn requires us to kind of find the root cause. And it might not be instant, it might not be on that one session. I'm not saying we're going to need a whole lot of sessions, but at least to let me prep and read up and discuss what I found, and let's have a kind of a clear head, a better understanding when I see that athlete or patient again.
Which comes back to your point where, like, initially, from the initial contact with the client, trying to get them to understand that this is sort of like a partnership, man. It's not you coming here and me fixing you. So when they have that understanding, they're more willing to kind of work together to find solutions, man. And it's not as in the case of, like, and sometimes even with you hear people saying they went to the GP, for instance. I'm not like riffing on GPs, but they go to the GP and the GP will say to them comfortably, I don't know what's going on here, I'm going to refer you to a specialist. But it says, I get the sense that as physios, we're almost taught, even in physio school, that, you know, when somebody comes to see you, you have to have all the answers. You have to have an answer to give that person. And that's, I feel personally, that's not necessarily a healthy thing, particularly to teach students, because as a newly graduated physio, I really didn't know anything.
I had a piece of paper and that was about it, you know, that said Wade qualified, and that was it. You know, you learn on the job, and like, which is the truth. You learn with time and clinical hours. That's how you learn.
But you're expected to know all the answers.
You're expected to know. You're expected to know. The textbook doesn't always tell you everything. But yeah, it's like you said. It's the ownership of the patient. A cool little example is like, we don't know what the patient feels at times. So why do we say, okay, lower back pain? Why do we say, okay, I'm going to ask you to do forward flexion for me, and we analyzing the posture and the biomechanics, but I want you to let me know when you feel any discomfort or any pain, and then you stop and you let me know. Without that communication, or without that rapport between therapist and patient, it's going to take us a whole lot longer. Patient goes all the way to the toes, and they come up and they say, oh my word, that was so painful, but like, why didn't you tell me? So exactly the same goes for like us planning and setting goals. It's not just me saying this is when I want you ready. It's like, how do you feel if we try to get you to this point doing this? If you don't feel comfortable, I should have enough tools in my box to like say, okay, if you're not comfortable doing this, we can do this. It might be a little longer, so it's very much kind of a negotiation between, but that's how you build the trust. That's how you build the rapport between yourself and your patient, or at least that's my 2 cents.
So why don't we get taught that in physio school? Why don't we get taught that way? I never experienced that.
I've never experienced that as well.
And like you said with Mike, who was your mentor, I had somebody afterwards when I was qualified kind of guide me in that way, or show me an example of how to think in that way. And I was like, but why wasn't I taught this way in physio school?
I can't really answer you there. I'd like to. It would be cool. I think it's a whole curriculum thing, and they try to keep the curriculum with international standards, or that's at least what one lecturer told me, and that's why they're still kind of teaching the shortwave diatherm and those things, even though we.
Whoa.
Exactly, like I did that in electrotherapy, and that's the last time I saw a shortwave diatherm. Never used it afterwards again, but it was part of the curriculum, and I think it's just kind of the international standards, and we're trying to keep with those international standards of all these things. But I'm like, in my case, it's like, why not get someone who has that kind of experience, get an Ian Meader in there, chatting to these students, and telling them, listen here, this is all good and well, but out there, this is how you gotta. It's okay not to know that. No, not okay not to know your work now to qualify, but in the real setting, it's fine to say like, I'm not too sure about this, but this is what I'm thinking, and that's a hypothesis, isn't it? When we find a patient, we're ticking off the boxes. That looks facet. Nope, that's disc. That's facet. Oh, facet, facet. So you hypothesizing, and the only thing is, we hypothesizing with the patient. We letting the patient know this is kind of, you got a mix of this and this and this. Let them know, like, be transparent, and I think you'll get better results that way, because you actually get the patient to buy in. And it's not like, here's 3 exercises, do them. And actually actually make it a team effort.
So let me throw a curveball at you. Where do you think you would have been now as a physio if you had been practicing that kind of thinking from, let's say, 2nd or 3rd year?
Exactly. I'm still learning to this day, and if I got a 2-3 year head start on that, it would have been amazing, understanding and working with those, like OMT exam, where you work with the patient and the examiners take you out of the treatment room and go to a separate little room, and then they ask you, all right, what's the hypothesis? And like, why don't we do the same thing but involve the patient in this, and say, listen here, like, let's stay here, ask me, let me tell the patient what I think, and you can examine me in that way. Say, listen here, I think that, and obviously they can, whatever needs to be asked has to be asked, and they can always ask, but let's involve that, and let's kind of teach that from like undergrad, so I don't know, I don't know if I hit that curveball.
You open up another can of worms with mentioning of the OMT. My feelings on the whole OMT culture, but I think that's probably a discussion for another day. But for me personally, I think we spend so much time on like almost focusing on these things that are supposed facts, you know, like this is a diagnosis, this is what a rotator cuff is, this is what a patellar tendinopathy is, you know, and in physio school, I mean, and we don't spend enough time like teaching students like how do you think, how do you take in information, how can we improve that system, rather than this is an assessment form, memorize the way you do that, and then go and apply it, you know. But not everybody takes in information in the same way, and it's difficult when you're working with 70 students or 80 students. I understand that, but I think the focus should be to get these students to kind of think about how they're thinking and how we go about it, and there are various different ways of doing these things, and particularly focusing on maybe like what is things like basic things like what is logic, what is, you know, reasoning, you know, what's the different types of reasoning and how we use it in a clinical setting. And I think these things can be explored more, and this is just, once again, just my 2 cents.
Yeah, exactly.
More than, you know, I don't know, spending, you know, 2 years on physics or chemistry or whatever it is, you know, in the undergrad, which is, I don't think that's, I'm not saying that that's not necessary, particularly,
or valuable.
yeah, in particularly in your understanding of biomechanics and being able to apply those things. But I think still there should be a lot of emphasis from first year, like, you know, when the students come in to almost shock them and say, look, this is going to completely shift the way you have been taught or been suggested that you think, but this is where we need to be, you know, and you are going to go on a journey into finding out about yourself more and exploring how to get to that place.
Undergrads might hate us, but how do you think just adding another subject in there, you know, like some, you know, no real exam, you know, I don't know how these things work, but like just clinical reasoning, like, you know, just throwing that curveball.
You sing into the choir, my man. I've been advocating this for so many years, and particularly the students that I've interacted with have been crying out for that, you know, and the recurrent theme that comes up is, why haven't we been taught in this way, you know? And it's a very difficult thing to answer because, you know, I'll put my hand up. I don't understand the mechanics and the politics behind setting up curriculum and teaching those things, but I do feel like if we are gonna say at the end of the day that we want a certain type of professional to graduate, you know, we have to kind of evaluate how do we get that person to that, man. And if one thing is consistently coming up when it comes to clinical reason and being able to apply thinking and apply your skills, you know, and critically evaluate those things, then certainly we have to try and teach that in a better way, you know. And yeah, it's a difficult thing because you're trying to change a culture, I suppose, and you're trying to change a massive machine, but yeah, I just feel like the students will definitely appreciate that.
And we kind of hoping, and that's kind of like we did when we chatted in the corridor talking about starting this thing, is that, you know, even if it's not an academic requirement, you know, at least if any of those undergrads, you know, kind of find us on whichever platform, you know, that, oh my word, you know, that's how it might be after I graduate, and like at least get that cogwheel turning a little bit before, you know, and like, you know, maybe it's okay for me not to know everything, you know, and I think as a student, you like, I need to know all of these things to be a great physiotherapist, you know, so when I graduate, you know, I need to know everything and kind of get them to understand that, listen, you know, you're going to be learning from the day you step into physio school and from the day you graduate from physio school. If you don't, you're not going to grow as a physio, or at least that's, you know, like that's what I think. You're not going to grow as a physio because, like I said, things are changing, you know, new studies are coming out, and it's okay to feel a little bit lost in all this wealth of information, but it's okay, you know, as long as you kind of know that and understand that and still willing to learn, you know. I think they'll benefit so much from that.
And another controversial thing, I mean, like slightly controversial, I would say, is that things that are always, well, in the recent past, tell students is that, you know, particularly when it comes to something that's bugged me for years since I was a student, is that and I only have experience of this in physio school, but from speaking to other medical professionals also, they've experienced the same thing. When you in an exam situation, it's as if you feel as if somebody's out to get you, man. And in my opinion, an exam, particularly a clinical exam, is just another learning opportunity. And often in physio school, we tend to make it such a pressurized environment that the student loses all sense of what it is to be there, man. It's about, evaluating what I've learned over this last however many years or terms, and then applying those skills. And you can only really get an idea of how well the student is doing at that if they are at their most comfortable, So now you're sitting there in an exam, and sort of in your periphery you can see the examiner kind of rolling the eyes
with the clipboard,
and
the pen, the shake of the head.
And I mean, to me that makes absolutely no sense, because you cannot evaluate somebody's abilities in a situation like that when they're not even focused on what they're doing. They're more focused on, am I doing the right thing, by trying to figure out
read body language, exactly,
which is, but yeah, having spoken to people in physio schools about this who do run the show, they're not really open to that kind of thing. It's more a case of the students have to deal with the pressure, so to speak. And to me that just doesn't make sense. It's another one of my pet peeves as well. I just think that we can do this thing so much better, and we don't have to be like almost like old school teachers, man. It doesn't have to be like that, because everything is a learning experience, and the students can learn so much more from an exam if they're comfortable, and you can help them along. Obviously not give them answers, but prompt them a little bit, get them going, get their thinking going a little bit, and that can only happen if they feel comfortable in that situation, because they're not going to want to be prompted, because they know, okay, if I'm going to ask a question, if I'm going to appear as if I don't know in an exam, or appear as if I
sign of weakness.
Yeah. You have to have the answers, and it has to come immediately. And nobody works like that. They don't have enough clinical experience, and certainly they're only gathering their theoretical knowledge at that time. So how can they make those decisions so fast? They just can't. And we make it doubly difficult for them by putting them under pressure. It's like holding a gun to your head. Okay, now assess this ACL or whatever. If you get it wrong, you get a bullet through your head. It makes no sense to me.
So, seeing that you've been throwing me a couple of curveballs, I want to throw one back at you, So, kind of what we're doing, we're trying to get kind of out there, social media, more media platforms and things like that. And there has been that little battle going on that we've seen of late, the whole manual therapy versus exercise. What's your take on that, sir?
Yeah, I find it very interesting that particularly, my take on this whole thing is, maybe we should just kind of like sketch it a little bit. So there's a big camp for manual therapy that says you can't do anything without mobilizing or manipulating tissues. You're not being a complete physio without doing that. And there's a other side of the fence, or another camp that says those things haven't been clinically tested enough, or if proven effective enough, and you were just wasting your time on low value treatments. And to me, I find it interesting when physios are always talking about toolkits and those sort of things. And like, in my opinion, if I'm going to do a job and I don't know what the job is that I'm going to do, if I'm going to a job, I want my toolkit to be as extensive as possible. I'm not necessarily going to use every tool, but if I think about that tool and it's not in my toolbox, then I can't do the job effectively. So I'm not going to discount everything. And there is research on, particularly a lot has been done recently on manual therapy and whether it's effective or not. And I still think there's still value in certain things, but it's when you are dependent on one particular tool or one particular skill set, and then suddenly you see something or you encounter something that's maybe outside of that skill set, then you try and fit that condition or that client within your toolkit, and that sometimes doesn't make sense to me, so I guess you can say I'm sitting on the fence, because I will go onto this side of the fence. I will use manual therapy when I think it's appropriate, and I will use exercise when I think it's appropriate, So I do put my hands on clients, and there are some clients that I don't put my hands on, And it's about well, like you said, communicating to me. I think if you can get that client to understand that this is a partnership and I'm going to give you the best advice that I possibly can to get you to where you want to be. And sometimes I'm going to advise exercise, sometimes I'm going to advise manual therapy, but it's always based or focused on trying to get you what you need at that particular time to get you where you need to be.
Yeah, I totally agree with you. I'm definitely on the fence as well. So why eliminate the famous jiu-jitsu coach John Dinner?
Yeah.
Why ignore 50%? You know. So it's basically, come on, man. Like, if you can't throw away your plinth and you can't throw away the whole rehab section, they kind of hand in hand. Like, if I have a very reactive, irritable joint, you know, I'm not gonna make you, you know, as much as I can try to do low load exercises. You know, sometimes I need to do a little bit of passive accessory movements just to kind of get things moving, get the brain to kind of understand that, look, it's moving at this depth, it's okay, you know. So it's a lot with the you know, the nervous system, the getting that to fire and getting the brain to understand, like, okay, this movement's it's safe for me now, you know, and I'm doing okay. And then you know, slowly transition and get them to do the movement while you perhaps creating a glide of the joint, and then slowly adding some resistance or like, you know, just a normal physiologically active movement, and then progressing in that way. Or someone comes in and say, listen here, I have knee pain, this is the issue, I only have knee pain when I land from a jump, you know, and there might be some tightness on the quad. Cool, we'll load it eccentrically to try to, you know, kind of use a muscle energy technique to get rid of that tightness. But what you need is actually, we need to load this guy to actually absorb that force on landing, and you know, and then, like you said, such patients like that, I might not put my hands on them, I might take them straight into that rehabilitation phase. I don't want to use the word box, but I always tell my patient, you either an acute patient or a rehab patient. You know, I might need to baby you out of that acute phase and then transition into the rehab, or, you know, you're actually okay, let's go straight into the rehab. Well, that's just how I see it.
I don't personally also, I don't think there's anything wrong with getting somebody comfortable enough so that they can do the things that they are required to do, whether it's task specific or whether it's goal specific. But for instance, if somebody is, for whatever reason, the athlete had a fight with his girlfriend, and now he's all tense, and now he comes to see you in the morning, and now you go, okay, let's go do some pull-ups to failure, you know. He's not going to want to do that, you know. So, and in that time that you often spend doing manual therapy with somebody, particularly somebody who you've built a relationship with, you get time to speak to them, to kind of also get time for them to also speak and deal with stuff, you know. And maybe all of a sudden his traps feel a little bit more relaxed, his mid-back feels a little bit more mobile, then he can go and he feels motivated to do it, you know, because all of that other pressure is not just necessarily hanging on him. So I don't necessarily see that there's a problem with it, but some physios have been very vocal about, you know, not doing that because it's not affecting you're not affecting anything on the tissue level, you know.
Yeah, but that's the other thing, you know, that's like what is it, the biomedical approach and tissue level, right? But the person's not just tissue, you know what I mean? So I always when I work with my guys, I'm always like saying, like, you know, I kind of want to get to know you. It's an important part. I want to kind of know what the psyche is right now, you know. I don't want to say we become friends, or, you know, it's not going to happen with everyone, but actually just get on a kind of some type of wavelength that I kind of understand, and I can kind of gauge where you at on a certain session, you know. And then I'm like, okay, you know, the mindset's good today, the body feels good today, let's push you, you know. Or, you know, all tight, it's not looking good, you know, let's spend a little bit low load session today, but let's kind of get the body to move passively in some sense, and go from there. So treating the tissue effectively is great, right? But sometimes we also have to realize that it's a human being, and we're not only treating the tissue, but we're treating the person, and that's where the whole clinical reasoning thing comes in as well. You know, I wouldn't say clinical reasoning to the body, but just holistically as a person, like, okay, what do I get the feel of, the patient today? He's very chatty today, so maybe we can, or I can see something's up, maybe it's exam time and, it's a little stress and, like you said, girlfriend broke up with you.
Yeah.
So, yeah, I think it's all good and well on paper. It might not be as effective as the other, but we have these tools and we're going to kind of have to read what's going to be effective for the person, not the tissue.
Yeah. Okay, so then let's get a little more controversial here.
And again, it's just our 2 cents, just our point of view, so I don't mind. Let's go.
Where do you fall on the more passive treatments? So, for instance, your electrotherapies, your dry needling, your acupuncture, those sort of things. Yeah. And I'll give you my take on it, if you want, or you can go first.
You go first. So you take the bullet or the hit first.
Okay, so once again, also this is just my opinion, and people are probably going to shout at me for this, but I don't think there's anything wrong with using the placebo effect in treatment as long as it's explained to a client.
Yeah.
But then again, also the flip side of that is once you explain the placebo effect, you take away its efficacy.
The power.
So,
yeah. But so in you saying that, you're basically telling me that electrotherapy is a placebo effect, Ian.
It depends on what you're using it for, when you're using it, and what you're using, basically.
Okay. So I usually when my guys ask me like, okay, what do you use? I say my kind of most powerful form of electrotherapy is my microwave, which I heat up my beanbag, which I heat up my beanbag, to create like heat.
Yeah.
I always try to be a bit more hands-on, but look, like you said, you got to be honest, but it takes away the effect of that placebo. But I'd rather spend, time, that 15 minutes on my patient, working with them either through rehab and exercise or hands-on, than getting them to do something like interferential, for example, which is, basically stimulating the muscle to relax the muscle, which I can tell my patient, put some heat on it afterwards. Once we're done here, go home and do that. And you can do that for as long as you want to. You can't overdose on heat, just don't burn yourself, is my line. But at least I've done a solid 45 minutes of therapist to patient work, being involved and not putting on something and stepping out for 15 minutes, or you get what I'm saying? So I usually say things you can't do at home, I will do with you. Whatever you can do at home, that's what you got to do.
Because let's be honest, I mean, like, the clients come to us for not what we do here, but what we have up here.
Exactly.
So them lying on the plinth, they might feel nice with the heat pack and the interferential ultrasound or whatever it is that you want to do. They might feel nice, but they can feel nice, like you said, with the beanbag at home, lying under the blankets, watching Netflix or whatever the case may be is. And you're kind of having the same effect, but they're not spending X amount on the physio session just to have a beanbag on them. They're not walking away with anything more than what they came before.
Yeah, sometimes, like we said, we're not just our opinion, but sometimes it's a little bit shocking to me that if I get someone that has been to a different physio, that they find it so strange that I'm not going to use any ultrasound or any electrotherapy modality on them, and like, oh my word, like, why am I doing these exercises? You're supposed to fix me.
That's what physio is.
This is, what are you doing? Like, I'll go to a personal trainer and, but I'm like, this is how we work here, or how I work as a physio. But yeah, man, like, I think a big part of this episode was just to kind of get not only us as therapists to think a little bit, but also like kind of get that insight to the people out there, the patients, to say like, maybe there is a different approach. Maybe I don't just go lie down, I get a nice massage, and I get things that go. That's usually what they do. Trying to describe what the machine is.
Oh, I thought you were doing something else.
This was the interferential pads, Ian. Yeah, like, you know, it's a little bit shocking and things like that, but like I said, like maybe it is time for that little bit transparency and that shift. That listen here, we trying to sort you out and not get you back here in 2 weeks' time. You know, the whole point of physio, I usually tell my guys, and they don't understand it because it's a terrible business model. Is the whole point of physio is to get you out of physio, you know, and not keep you here for the rest of your life. You know, give you the tools to manage this by yourself. So if ever I feel like it's coming back, stop my exercises. Maybe I just, you know, top up. So yeah, that's just kind of my approach.
Yeah, I think it's also it was good to discuss all these things now, because I think it's important for people also to realize, like we were talking about, the power of saying I don't know. You know, I think we should use it more often. I think we don't give clients enough credit, and I think that's where a lot of the problem lies. We tend to treat them either as idiots or babies. You know, like I have to do everything for you. I have to dumb everything down for you, but you know, clients should learn to understand, or we should make them more aware that they are partners in this thing, you know, and it's a two-way street. You have to be as active in the therapy as I am, you know. Exactly. That's the only way it's going to work. And once we get that, I think people will be more open to trying different things, you know, figuring out, okay, this didn't work, but I'm going to try this now, and be okay with that, you know, because it's a two-way communication thing. And,
so hopefully we got our point across today.
Oh, that's my 2 cents.
That's our 2 cents.
Our 2 cents.
Just our 2 cents. I think that's a wrap, man. Thanks, guys. Hopefully you got something out of our 2 cents. Hopefully we see you back here.